I would like to start with the heart. And this is a painting from Marcello Fogolino. Is Madonna with child on the throne and two saints, Job and Gotthard. On your left, there is Job. Job is the first documented historic patient with a skin disease. I like to think that it's psoriasis, but of course differential diagnosis is open. And Job has been used as a model for representing skin disease during the century by several artists. On the right, you can see Gotthard. And Gotthard is the patron of patients with gout. So the amazing thing is that also in the art, in 1500, the association between psoriasis and metabolic disorder is represented. And likely the commissioner of this painting had both psoriasis and metabolic syndrome, and he was asking help for this condition. So the content of my presentation will be IL-17 signaling in psoriasis pathogenesis, IL-17 signaling in metabolic disease in patients with psoriasis, and to reply to the question, does blocking IL-17 signaling improve metabolic parameter in patients with psoriasis? The pathogenic cytokines expressed in the skin, in the psoriatic skin, include interferon, TNF, IL-17. You can see the cell expressing IL-17 and IL-22. TNF and IL-17 synergize in modulating chemokine synthesis in cultured keratinocytes. So when they both are present, the stimuli for inflammation is higher. IL-17 is a family of cytokines that play a central role in host defense, inflammation, and barrier protection. And the IL-17 pathways is very well established in psoriasis, and blocking IL-17A, F, and the receptor is a very powerful strategy in treatment of psoriasis, but also in the treatment of psoriatic arthritis, because particularly for the development of enthesitis, IL-17 play a very important role. So in summary, IL-17 signaling is a key driver of psoriasis pathogenesis by driving chronic inflammation, keratinocyte hyperproliferation, recruitment of immune cells, and IL-17A acts a key effector cytokine in the IL-23 Th17 axis, making it a major therapeutic target. So far, so good. Is IL-17 signaling involved in metabolic disorder in patients with psoriasis? This is a very important paper. IL-17 driven metabolic pathway deliver vital signs for tissues homeostasis, either in healthy condition and also in disease condition, in disorder. In particular, the metabolic regulation of IL-17 is involved in tissue repair, adipogenesis, thermogenesis, autoimmunity, fibrosis, tumorigenesis. So cellular and organismal metabolic homeostasis cannot be sustained without appropriate temporally and spatially regulated IL-17 signaling, at risk of damage to tissue with clinical metabolic function. In parallel, metabolic regulation underlies many IL-17-driven pathologies. And IL-17 metabolic regulation during disease acts at keratinocytes level And the metabolic regulation is related to the reprogramming of urea cycle that is, as a cellular outcome, induce the expression of pro-inflammatory genes. Similarly, in the IL-17 mediated metabolic regulation is involved in the increased cholesterol uptake. We have already discussed these issues of cholesterol with Alvaro and Joe before. There is a metabolic coordination between skin epithelium and type IL-17 immunity that sustain chronic inflammation, specifically in psoriasis. Hypoxia-inducible factor 1 alpha activation in psoriasis epidermid drives glycolysis into the cells and consequently lactate production. Lactate acts as a metabolic signal that enhances IL-17 driven gamma delta T responses. In mouse model, the dilating of epithelia hypoxia-inducible factor 1 alpha reduce skin pathology, including vascular and neural remodeling. So this finding suggests that epithelial immune metabolic crosstalk sustain chronic inflammation in psoriasis and may be a therapeutic target. IL-17 driven polyamine production in keratinocytes reprograms their metabolism, stabilize self-arraying antigen complexes, and activate dendritic cells, thereby amplify chronic inflammation in psoriasis. And cholesterol modulates IL-17A signaling in psoriatic keratinocytes by altering gene expression and inflammatory responses, suggesting a mechanistic link between lipid metabolism inside the cell and chronic inflammation. Elevated cholesterol level also regulates the expression of chemokine in keratinocytes via activation of NF-κB. Metabolic inflammation associated with IL-17 causes non-alcoholic steatohepatitis and hepatocellular carcinoma and drive this progression by enhancing hepatic immune cell infiltration, fibrosis, tumorigenesis, positioning IL-17A as a key pathogenic mediator and potential therapeutic target. IL-17 and Th17 cell contribute to the pathogenesis of both type 1 and type 2 diabetes by promoting chronic inflammation, beta cell dysfunctioning, insulin resistance, positioning them as a potential therapeutic target. This algorithm was a little bit complex to me. I simplified by using artificial intelligence, and I think that is more easy to follow. IL-17 connects immunity and metabolism, contributing to insulin resistance at different level. Adipose tissue level, because inhibits insulin receptor signaling, liver level, induces steatosis, inflammation, and reduces hepatic insulin sensitivity. At the skeletal muscle, blunts insulin-stimulated glucose uptake. IL-17 is also involved in atherosclerosis and cardiovascular disease with a good, bad, and unknown effect. The good, because IL-17 can stabilize atherosclerotic plaques by promoting collagen deposition and strengthening the fibrous cap. The bad, because IL-17 is a potent pro-inflammatory cytokine, recruiting neutrophils and stimulating endothelial cells. The unknown, because the net effect of IL-17 in humans atherosclerosis remains a little bit controversial, protective in some contexts, harmful in other contexts, and the pro-atherogenic effect and anti-atherogenic effect of IL-17 have been described. So this is my view. I'm aware that it's a very simplified. I am a simple guy, an easy guy, so I can show you just simple things. And the concept is the concept of spillover. So the inflammatory mediators released from psoriatic lesions spill over into the systemic circulation. And these include IL-17, but not only IL-17, also TNF and interferon, because these cytokines synergize among them, between them, and they act at different level: skeletal muscle, adipose tissue. We have listened to a beautiful lecture from Mehal regarding this important adipokines role, and the liver. And on long term, the chronic inflammation at different level could favor endothelial dysfunction and finally atherosclerosis. So in summary, IL-17 drives metabolic dysfunction in psoriasis at cellular level and organ level. Systemic inflammation and insulin resistance, endothelial dysfunction and atherosclerosis, adipose tissue remodeling, hepatic and lipid metabolism. So IL-17 is in the core of immune metabolic crosstalk. The final question is, does blocking IL-17 signaling impact metabolic parameter in patients with psoriasis? The first message is that blocking IL-17A is safe in patients with metabolic syndrome, particularly for the liver, but particularly also for the other metabolic parameter. This is my experience, real life experience, but this is from 19 phase 3-4 clinical trials. Traditional risk factor, BMI, fasting glucose, and blood pressure remain stable throughout 1 year of patient treated with secukinumab, and similarly for patients treated with ixekizumab from the Uncover 1, 2, 3 trials. However, secukinumab reduced high-sensitive CRP and neutrophil lymphocyte ratio were reduced by secukinumab over 52 weeks. The flow-mediated dilatation, that is a biomarker of endothelial dysfunction, was significantly improved compared with baseline in the group of patients treated with the labeled dose of secukinumab. And anti-IL-17 therapy showed a significant reduction in non-calcified coronary plaque burden compared to non-biological therapy. This study from Joel did not find significant changes in aortic inflammation or markers of advanced lipoprotein characterization, adiposity, or insulin resistance were observed with secukinumab treatment compared to baseline. The last part is on the liver, and in this study pool data, we investigate the effect of bimekizumab on liver fibrosis parameter, particularly using this score, fibrosis index score 4, and those patients with high baseline liver fibrosis risk, this score decreased from baseline to week 16 and remained consistent to year 4. So in summary, IL-17 inhibitors are safe in patients with metabolic syndrome. They do not worsen cholesterol, triglycerides, glycemia. IL-17 inhibitors lower CRP and other inflammatory markers, which correlates with improved metabolic outcome. By reducing systemic inflammation and endothelial dysfunction, IL-17 inhibitors may lower cardiovascular risk over time, but this remains to be proven. And since we have discussed so far biomarkers, IL-17 like a biomarker, I show you my favorite biomarker from Valpolicella, and there are roses in front of the vineyard, and whether there are healthy flowering roses in front of the vineyard, this is a biomarker, this is a predictor of grape health for the harvest. And with this, I thank you very much for the invitation and for the attention.
Thank you, Paolo. We have time for one or two questions. Any questions from the audience? If not, I'll ask you one. Thinking about IL-17 as maybe more of like an epithelial type cytokine, do you think there's a direct involvement of it in the metabolic, processes or atherosclerosis? What is your take on that?
Yeah, the effect of IL-17 in atherosclerosis could be controversial because it's not IL-17 alone that play a role independent from the other cytokines, but also in synergy with TNF and with other cytokines, and also depend on the phases of atherosclerosis. So the effect, I think, is not black or white, but is more complex and also depending from other cardiovascular risk factors.
Thank you. That was very clear. And sorry to see that you're not able to kind of come and be with us here.
Yeah. I'm sorry.
Thank you for joining us over Zoom. We really appreciate that.
Thank you.